A 12-year-old boy was playing football and caught the ball on the end of the index finger. He later on felt pain in the base of the finger and was unable to move the finger. Brought to the emergency department. At the base of the finger, pain would be differential diagnosis would be a fracture of the distal metacarpal, sprain of the metacarpophalangeal joint, or dislocation of the metacarpophalangeal joint. You further on move on to examine the patient. The finger is in slight hyperextension at the metacarpophalangeal joint and flexion at the PIP joint. There is no active range of motion at either joints. The skin is intact and the index metacarpal head is prominent at the palm. Capillary fill is normal and the remainder of examination is normal. An X-ray is done which reveals a lateral view demonstrates a dorsal dislocation and the widening of metacarpophalangeal space. Widening denotes interposed soft tissue. No fracture is seen. The diagnosis here is a complex dorsal metacarpophalangeal dislocation. The hint being there is a gap or space caused by interposed tissue on lateral view. The widening of metacarpophalangeal joint and mild hypertension favors a complex dorsal dislocation of metacarpophalangeal joint. The differential diagnosis includes subluxation of metacarpophalangeal joint, but the joint is usually hyperextended at 60 to 80 degrees with subluxation. Dorsal dislocation results from hyperextension injury. The small and index finger are more commonly involved. It is important to differentiate simple dislocation, which can be reduced by close manipulation, and complex dislocation, which sometimes require open reduction. A complex dislocation typically present with dorsal displacement with slight hyperextension of the proximal fillings relative to the metacarpal. The interphalangeal joint are slightly flexed. In the index finger, the proximal phalanx is usually deviated towards the long finger. The metacarpal head is prominent in the palm, and careful inspection revealed pathognomic skin puckering at the proximal palmar crease. Swelling is, however, quite obscure and therefore radiograph is essential. There is a concept of parallax which has been described, meaning that there is lesser deformity in complex dislocations compared to the simple dislocations. In this subject, the volar plate is a key structure blocking the reduction in complex dislocations. Hyperextension of the metacarpophalangeal joint avulses the volar plate from the weaker proximal attachment at the metacarpal neck and displaces it over the dorsum of the metacarpal head. The deep transverse metacarpal ligament is partially torn at its attachment to the side of the volar plate. Now we are talking about index finger. In index finger, the metacarpal head becomes trapped by the volar plate dorsally. The lumbricals go radially and the flexor tendons go ulnar side. Longitudinal traction tightens the flexor tendons and lumbrical, creating a noose effect around the metacarpal head. Thus, the recommendation that close reduction should be performed with wrists slightly flexed to relax the flexor tendons and lumbricals. Even with the wrists flexed, the collateral ligaments may prevent adequate distraction of the joint to allow escape of the volar plate and reduction of the joint. Therefore, the key to open reduction is division of proximal portion of the volar plate to allow the metacarpal head to slide through it. In our case, a close reduction was attempted. The wrist was flexed and pressure was applied at the dorsal base of the index proximal phalanx. No change of alignment was achieved and the patient was taken operative room on the same date. Open reduction was performed under general anesthesia through the dorsal approach. Surgical exposure was gained through an ulnar base triangular flap over the dorsal aspect of the metacarpophalangeal joint. The ulnar sagittal band was incised and the extensor tendon fractured radially. The dorsal capsule was incised longitudinally in to expose the joint. A small chondral defect attached with the soft tissue was also found. The fragments were reflected proximally, revealing the base of the proximal fillings and the volar plate attached and interposed over the metacarpal head. The proximal portion of the volar plate is incised longitudinally in the midline. The proximal fillings was then easily reduced and pressure by just applying a dorsal pressure at the base. The metacarpophalangeal joint reduced state in 0.9 degree of flexion, and there was no laxity of the collateral ligaments when joint was flexed. The chondral fragment was reduced and stabilized. The ulnar sagittal band was repaired. The skin was closed in layers, and subcuticular stitches were applied for the skin. The hand was immobilized with the volar splint and metacarpophalangeal joint in 6 degree flexion and interphalangeal joint extended. Postoperatively, 1 week splint was applied, and then after range of motion exercise were allowed, and with a body strap tapping to the adjacent finger. Full active extension and flexion were achieved at 8 weeks' time. This is not the only way operative intervention can be expedited. Alternative longitudinal incision through the extensor tendon is another approach. In that, a tendon incision is given longitudinally, the tendon is dissected. Another way would be to go on for a volar approach. A tendon splitting approach is now advocated by some to allow early range of motion. A volar approach can be used for open reduction of complex dorsal dislocation. The digital neurovascular bundle is usually tented up on the metacarpal head and can be easily injured. The structures surrounding the metacarpal head are serially divided at the volar approach with a longitudinal incision through the volar plate. Because the volar plate is strapped dorsally, it's sometimes difficult to dissect it. Next, the natatary ligaments is divided, followed by superficial transverse metacarpal ligament. The primary argument is that the volar approach is that division of volar structure is necessary for reduction of the joint. Anyhow, some of the surgeons contradict that the only thing which needs to be incised is volar plate, which is present dorsally. The advantages which we feel with the dorsal approach is that the neurovascular bundle is safe. The volar plate can be easily visualized and divided because it's strapped dorsally over the metacarpal. The only disadvantage of the dorsal approach is that you have to go through the extensor mechanism of the exposed joint. Complications which can occur are stiffness, degenerative arthritis, digital nerve damage, and misdiagnosis resulting in delayed treatment. Stiffness is best prevented by early range of motion, using extension blocking splinting to allow for early range of motion if there is instability after reduction is possible. If the joint is stable, body tapping is also sufficient. Degenerative arthritis may arise if there is articular damage during the dislocation.